Welcome to the session of RadOnc Smart Review. We continue our discussions on essential physics concepts for radiation oncology practice.
That's right.
Today, we're zeroing in on two, really cornerstone imaging modalities: computed tomography, CT, and magnetic resonance imaging, MRI.
The big two for planning, really.
Exactly. We'll explore the nuts and bolts of how these images get made, their absolutely crucial role in treatment planning,
Couldn't do modern radiotherapy without them.
and key safety considerations, especially, with MRI.
Oh, yeah. MRI safety is a whole different ballgame. Very important.
But before we dive into CT and MRI themselves, we should probably start with the thing that lets them all talk to each other, right? The sort of universal translator.
Absolutely. Let's start with DICOM. You hear it called the digital glue of radiology, and honestly, it's the glue for modern radiation oncology, too.
Digital glue, I like that.
Think about it. You've got images coming from different scanners, CTs, MRIs, PT scans, maybe.
From different companies even.
Exactly, different vendors. Then you have your treatment planning system, your simulation software, your R&V system, the Linacs. How do they all manage to communicate?
It seems like it should be chaos.
It would be chaos without a standard. They achieve this seamless communication, by speaking a universal standard language called DICOM.
DICOM, D-I-C-O-M, and it stands for?
Digital Imaging and Communications in Medicine.
Okay.
It's more than just a file format, you see. It's a whole protocol for handling, storing, printing, and transmitting medical imaging information. Think of it like, the Esperanto for medical images and all the data that goes with them.
It's universal language.
Precisely. Without DICOM, trying to get equipment from vendor A to talk to software from vendor B, it would be a nightmare. Probably impossible, really.
Okay, let's unpack this a bit more. A DICOM file isn't just the picture, the grayscale image you see on the monitor.
Oh, far from it. A DICOM file is a really comprehensive package. It's designed to make sure every single piece of information you need to interpret that image, use it, understand it, and crucially for us, plan treatment with it is right there.
Okay.
It typically contains two main parts sort of bundled together.
Right.
First, there's the header. Think of this as the metadata. It's like the ID card and the technical manual for that image all rolled into one.
So patient name, ID.
Exactly. Essential patient info, name, ID, date of birth. Seems basic, but critical for making sure it's the right patient. Then study details, the date and time of the scan, the modality, CT, MRI, whatever hospital where it was done.
It'll just track where it all came from.
Right. And this is where the really important technical stuff lives too.
Like how the image was actually taken.
Precisely. The header stores crucial technical parameters. For a CT scan, you'll find the KVP, the MA's settings.
Kilovolt peak in milliampere seconds.
Yep. For an MRI, it'll detail the pulse sequence parameters, the TR, the TE, things we'll get into later. These aren't just for curiosity. They affect image quality and sometimes how you process the image.
Okay.
And very importantly for us in RadOnc, the header includes spatial information. This is the geometry stuff.
Like slice thickness.
Exactly. Slice thickness, pixel spacing, how big each pixel is in millimeters, and this exact location of the slices relative to some anatomical reference point.
That sounds critical for planning.
It's absolutely vital for geometric accuracy. You have to know the real-world coordinates of every point in that 3D image volume to correctly draw your targets, your organs at risk, and make sure your beams are aimed perfectly. Millimeters truly matter here.
So the header gives us the who, when, where, and how, including the exact size and position. What about the picture itself?
That's the second part. The image data. These are the actual numbers, the pixel values that create the image you see. For CT, these values are related to Hounsfield units.
We'll get to those.
We will. For MRI, there's signal intensities related to tissue magnetic properties. This is the visual information. But, without the header, the image data is just a meaningless grid of numbers. You wouldn't know whose body it is, what kind of scan, where it was taken, or how big anything is.
Right. Context is everything. Header is context. Image data is content. Now, you mentioned special DICOM things for radiation oncology. These are important for boards, I hear.
Yes, absolutely high yield for boards, and you use them every single day in practice. DICOM has specialized extensions called DICOM RT objects, RT for radiation therapy.
Okay.
These are specific DICOM files designed just for our treatment-related data. You absolutely need to know these.
Is there an easy way to remember the main ones, like a mnemonic?
Yeah, the one we talked about works well. Plan structurally. Dose images.
Plan structurally, dose images. Okay.
Let's walk through that. First, structurally refers to the RT structure set. This DICOM object stores all the geometric definitions. Think of all those contours.
The GPV, PTV, OARs.
Exactly. Gross tumor volume, planning target volume, organs at risk, all the things physicians and dosimetrists draw on the planning images. This object contains the spatial outlines, the coordinates of every single structure. If this file gets corrupted or is wrong...
Your whole plan is built on shaky ground.
Precisely. That's the structurally part defining the anatomy and the disease.
Okay, next is plan.
Right. RT plan. This object holds the blueprint for the radiation treatment itself. Every single parameter describing how the radiation beams are delivered.
Like beam energy angles.
Everything. Beam energy, gantry angles, couch angles, collimator angles for every beam, the monitor units, MUs, for each field, the MLC positions.
Multi-leaf collimator.
Yep, that shapes the beam. And the overall dose, prescription, total dose, dose per fraction. It's literally the set of instructions for the linear accelerator.
Machine instructions. Got it. So that's plan. Next is dose.
RT dose. After the treatment planning system calculates the dose distribution based on the RT plan and the patient's anatomy.
Using the CT scan and the structure set.
Exactly. That complex 3D map of where the dose goes is stored in the RT dose object. It's essentially a grid of voxels covering the patient, each assigned a calculated dose value.
This is what we look at with DVHs, right? Dose volume histogram.
Exactly. You use this RT dose object to generate your DVHs and evaluate if your plan hits the target and spares the normal tissues properly.
Okay, that's dose. Last one is images.
RT image. This object stores associated images that are part of the treatment process but aren't necessarily the primary planning scan itself. Things like DRR.
Digitally reconstructed radiograph.
Right. Generated from the CT, they simulate what the beam sees. Also, portal images, ABESs or port films taken on the machine to verify setup.
The daily imaging.
Can be, yeah. Or even setup photos. They're verification or documentation images linked to the treatment course.
Okay, so plan structurally, dose images gets us RT plan, RT structure set, RT dose, and RT image. Makes sense. Why is having this standard DICOM and these RT objects so incredibly critical for you listening, practicing radiation oncology?
It all comes down to patient safety and treatment accuracy, especially in today's world with equipment from so many different manufacturers.
Interoperability.
That's the key word, interoperability. DICOM ensures that the CT scanner from Company A sends images that the planning system from Company B can understand.
Which generates an RT plan.
That the LINAC from Company C can read and deliver accurately, all while the patient's info is tracked in the record and verify system from Company D.
Wow.
If you didn't have DICOM, you'd be manually re-entering data, trying to convert between proprietary formats. It would be incredibly slow, super prone to errors.
Dangerous, really.
Absolutely dangerous.
Yeah.
Robust QA would be almost impossible. DICOM provides that standardized framework. It lets us reliably transfer the patient's images, contours, plan, dose, everything through the entire workflow from sim to the last fraction. It's the foundation for safe, modern radiotherapy.
Okay, so DICOM is like the invisible backbone, making sure all these complex machines play nicely together for each patient. Right, let's move on to our first big imaging modality, computed tomography, CT. You often hear it called our window to electron density in RadOnc. Why electron density specifically? Why is that the key property for us?
Well, CT is the absolute workhorse in our field, primarily because it gives us that vital electron density information, and we need that for accurate radiation dose calculations.
Why electron density, though?
Because when high-energy photons, or particles like protons, travel through tissue, how they interact, how much dose they deposit, depends heavily on the number of electrons per unit volume in that tissue. That's electron density.
Makes sense.
Tissues with higher electron density, like bone, they attenuate radiation more strongly. They affect the beam differently than low-density tissues like lung or air. So to calculate dose accurately, you absolutely need a precise map of electron density inside the patient.
Got it. Electron density is the magic ingredient CT provides for dose calcs. So how does a CT scanner actually measure something that lets us figure out electron density? What's the physics going on inside that donut?
Okay, so at its core, a CT scanner is really a sophisticated X-ray machine. But instead of just taking a 2D shadowgram, it takes cross-sectional images by measuring how X-rays are attenuated or weakened as they pass through the body from many different angles.
Okay.
Here's the mechanism. You have an X-ray tube similar to a regular diagnostic one operating at diagnostic energies, typically 120 to 140 kilovolt peak, kVp.
Right.
This tube is mounted on a rotating ring called a gantry. As the gantry spins around the patient, the tube emits a beam of X-rays, usually fan-shaped in older scanners, or more commonly now, cone-shaped in multi-slice scanners.
And these X-rays aren't just raw, there's filtering.
Yeah, good point. They are filtered, usually through thin metal sheets like aluminum or copper. This removes the lower energy X-rays from the beam. We call this hardening the beam.
Why do that?
Couple of reasons. It actually improves image quality by reducing certain artifacts, which we'll talk about. And importantly, it reduces the radiation dose to the patient's skin because those really low energy photons would just get absorbed superficially without contributing much useful information deeper inside.
Makes sense. So the beam is a bit more penetrating.
Exactly. The average energy of this hardened beam is roughly, say, 1/3 to 1/2 of the peak KVP setting, depending on how much filtration is used.
Okay, so tube emits filtered X-rays while rotating. Then what?
On the opposite side of the patient, also mounted on the gantry, is an array of detectors. Hundreds or thousands of tiny detectors.
And they measure.
They measure the intensity of the X-rays after they've passed through the patient. As the gantry rotates, this measurement happens from many, many different angles.
So they're basically measuring how much the X-rays got weakened or stopped by the patient.
Precisely. That's attenuation measurement.
Wow.
As X-rays pass through different tissues, bone, muscle, fat, air, they get attenuated differently.
Because tissues have different properties.
Right. At these diagnostic energies, the main ways X-rays interact are photoelectric absorption and Compton scatter. Remember those from basic physics?
Vaguely. Photoelectric depends on atomic number, Compton on electron density.
You got it.
Yeah.
Photoelectric effect is more important at lower energies and in high Z materials like bone or contrast. Compton scatter is more dominant at these energies in soft tissue and depends mostly on electron density. The CT system measures the total attenuation along each path from the tube to each detector element. It quantifies this as the linear attenuation coefficient, usually represented by the Greek letter mu for the tissues along that path.
Mu, that's the fraction of photons removed per unit thickness, right?
Exactly right. It's a property of the material and the X-ray energy.
And this is where the computed part of CT comes in, taking all those most measurements and making a picture.
Yes, exactly. Image reconstruction. This is where the heavy computing happens. All those attenuation measurements, thousands, maybe millions of them taken from all the different angles, are fed into a powerful computer.
And it does some fancy math.
It's very fancy math. Complex algorithms are used to reconstruct a cross-sectional map of the mu values within the patient's slice. The most common algorithm you hear about is filtered back projection.
Filtered back projection, okay.
The result is a grid of tiny 3D pixels called voxels, where each voxel on the image is assigned a specific mu value based on all the measurements that pass through it.
But we don't look at mu values on the screen, do we? We see Hounsfield units. What are those? Why the extra step?
Good question. Hounsfield units, or HU, are simply how those raw mu values are scaled and standardized. It makes them easier to work with and compare. The scale is set relative to the attenuation of water.
Water is the reference point.
Exactly. The formula is basically HU equal 1,000 times mu of the material minus mu of water divided by mu of water.
So by definition, water is
0 Hounsfield units,
Yeah.
by definition.
And there are other key HU values we absolutely need to know for boards, for practice.
Yes, absolutely essential. Memorize these. Air is way down at approximately negative 1,000 HU because it barely attenuates X-rays compared to water.
Okay. Air Nash 1000. Water 0.
Dense bone is way up, typically around positive 1,000 HU, sometimes even higher. It attenuates X-rays much more strongly.
Bone plus 1000.
And other tissues fall in between. Fat is usually negative, around maybe negative 100 HU. Muscle is positive, around plus 40 HU. The key thing to remember is that Hounsfield units are linearly proportional to the measured linear attenuation coefficient.
Okay, now here's the really critical part for radiation therapy. How do these Hounsfield units connect back to that electron density we need for dose calculations? This is the core link, right?
This is the absolute crucial link. Understanding this is fundamental. There's a reasonably good correlation you see between the Hounsfield unit value measured by the CT scanner and the actual electron density of the tissue, the number of electrons per unit volume.
Reasonably good, but not perfect.
Not perfect, but good enough for accurate dose calculation if done correctly. Our treatment planning systems, the TPS, exploit this correlation using a CT to electron density calibration curve.
A calibration curve, how's that made?
It has to be specific to the actual CT scanner you're using for planning scans. You generate it by scanning a special phantom.
A phantom with different materials inside.
Exactly. A phantom containing inserts made of materials with precisely known physical densities and electron densities, things like water, different plastic plugs that mimic bone, lung, muscle, adipose tissue. You scan this phantom on your CT scan.
And the TPS measures the HU values for each known material.
Right. The TPS software measures the average HU value within each known material insert in the phantom scan. Then, it plots these measured HU values against the known electron densities, relative to water usually, of those materials. That plot, that relationship, is your CT to electron density calibration curve.
Ah, so it's like a lookup table or a function.
Yeah.
This HU value corresponds to this electron density.
Precisely. The TPS takes the HU value of every single voxel in the patient's CT scan, looks it up on that scanner-specific calibration curve, and assigns the corresponding electron density value to that voxel.
And that creates the 3D electron density map the TPS needs.
Yes. That resulting 3D map of electron densities is absolutely essential for the TPS physics engine to accurately calculate how the radiation dose gets absorbed and scattered throughout the patient's body. Without an accurate electron density map, your dose calculation, especially near inhomogeneities like lung or bone, would be significantly wrong.
And you mentioned this depends on the scanner settings.
Critically important point. This calibration curve depends on the CT photon beam energy, the KVP setting, and the beam filtration. So you have to perform this calibration for the specific KVP settings you use clinically for planning scans. If your calibration was done at 120 kVp, but you scan a patient at 140 kVp for
the HU values might not translate correctly to electron density.
Exactly. The relationship changes slightly with energy, so using the wrong calibration curve can introduce systematic errors in your dose calculation. Consistency in scanning protocols and calibration is key for QA.
Got it. Consistency is crucial. Now, modern CT scanners are incredibly fast. They often use something called helical or spiral scanning. Can you explain that, maybe compared to older methods, and introduce the idea of pitch?
Sure. Helical or spiral scanning is pretty much the standard now. The oldie method was called step and shoot. The table would move the patient to the position for the first slice, stop. The gantry would rotate 360 degrees to acquire the data for that slice, stop. Then the table would move to the next slice position, stop, acquire, and so on.
Sounds slow.
It was much slower. In helical scanning, the patient table moves continuously through the gantry, while the X-ray tube is continuously rotating and acquiring data. So the path traced by the X-ray beam around the patient is a helix or a spiral.
And that's faster.
Much faster. Allows for scanning large volumes quickly, shorter breath holds for the patient, reduces motion artifacts, and lets you reconstruct slices retrospectively at any position along the scanned length.
And pitch is related to this helical motion.
Yes. Pitch is a key parameter specifically for helical scanning. It describes how fast the table is moving relative to the width of the X-ray beam.
Okay, is there a formula?
Simple one. Pitch equals table movement per rotation beam width.
Table movement per 360-degree rotation divided by the total width of the beam along the patient axis.
Exactly. The beam width here refers to the total collimated width in the longitudinal direction, z-axis, at the center of rotation.
Why does pitch matter?
It affects scan time, patient dose, and image quality, particularly along the patient's length, z-axis resolution. It's a trade-off.
Okay, explain the trade-offs. What if pitch is 1?
A pitch of 1 means the table moves exactly 1 beam width during each rotation. This gives you contiguous coverage in the acquired data, no gaps, no overlap along the z-axis in the raw data helix.
What about pitch greater than 1, like 1.5?
Pitch greater than 1 means the table moves faster, covering more anatomy per rotation, so faster scan time, which is good. It also generally reduces patient dose because each part of the patient is irradiated for less time overall. However, it creates small gaps between successive turns of the data helix. The reconstruction algorithms have to interpolate across these gaps.
Does that affect image quality?
It can slightly degrade the resolution along the z-axis compared to pitch 1, but modern algorithms handle it pretty well. It's often used to speed things up or reduce dose.
And pitch less than 1, say 0.5.
Pitch less than 1 means the table moves slower than the beam width per rotation. This results in oversampling the data helices overlap along the z-axis. This can improve image quality, especially the longitudinal resolution, because you have more data points. But the downside is
higher dose.
Higher dose, yes, because the same tissue volume gets irradiated multiple times by overlapping beams, and the scan takes longer. So typical clinical pitch values are usually somewhere between 0.5 and 2, depending on the application and what trade-offs you're willing to make.
Okay, so pitch is one factor influencing the scan. What else affects the quality of the CT image we actually look at for planning?
Several key factors contribute to CT image quality. First, contrast resolution. This is the ability to tell the difference between tissues that have only slightly different X-ray attenuation properties, like distinguishing gray matter from white matter or seeing a subtle liver lesion.
What affects contrast resolution?
Things like the KVP setting lower KVP can sometimes increase contrast for high Z materials due to more photoelectric effect, but it also increases noise and dose. Higher MAS helps more photons mean better statistics, better contrast detection. Slice thickness and pixel size also play a role. Larger voxels tend to average out noise, which can help see low contrast objects, but hurt spatial resolution.
Okay, second factor.
Spatial resolution. This is about seeing fine details. Can you distinguish two small objects that are very close together? It's like the sharpness of the image.
What improves spatial resolution?
Thin slices are key. Small pixels, which means using a larger image matrix size for the same field of view. Also, a smaller focal spot on the X-ray tube gives a sharper beam profile. And using high-resolution detectors.
And thin slices are super important for us in RT, right? For accurate contouring.
Absolutely critical.
Yeah.
Especially for small targets or structures near critical organs where the shape definition has to be precise, or if you expect sharp dose fall-off. Thick slices average the anatomy over that thickness, blurring details and making accurate contouring impossible.
Makes sense. What else affects quality?
Noise.
Yeah.
This is the grainy or mottled appearance you sometimes see, especially in low-dose scans. It looks like static or fuzziness.
What causes noise?
It's mainly due to quantum model, the random statistical variation in the number of X-ray photons detected per voxel. Fewer photons detected means more relative fluctuation, more noise.
So how do you reduce noise?
The main way is to increase the MAAs, use more photons, but that increases patient dose.
The eternal trade-off.
Exactly. Thicker slices also reduce noise because you're averaging the signal over a larger voxel volume, collecting more photons per voxel. Again, trade-off with spatial resolution.
Okay, contrast resolution, spatial resolution, noise, anything else?
Artifacts. These are features in the image that don't correspond to the actual anatomy. They can degrade image quality and, importantly for us, sometimes affect the accuracy of the HU values.
Examples.
Patient motion is a common one, causing blurring or streaking. Metal implants are a big problem. They cause severe streaks because the metal blocks almost all X-rays, confusing the reconstruction. And then there's beam hardening artifact.
You mentioned beam hardening earlier with filtration. Can you explain the artifact itself? This seems really relevant for dose calculation accuracy.
Yes, beam hardening artifact is very relevant. Remember, the CT X-ray beam isn't monoenergetic. It contains a range of energies up to the set KVP. As this beam passes through dense material like bone or high Z material like contrast agent, the lower energy photons in the beam get absorbed more readily than the higher energy ones.
So the beam gets harder. Its average energy increases.
Exactly. The beam that emerges is harder. Now, the problem is that the tissue attenuation coefficient, BO, depends on energy. The reconstruction algorithms generally assume a more consistent beam energy spectrum. When the beam hardens significantly as it passes through parts of the patient, the measured attenuation values become inconsistent with that assumption.
And that shows up as artifacts.
Yes. It can cause cupping, where the center of a uniform object, like the brain or liver, appears artifactually darker, lower HU, than the edges. It can also cause dark streaks or bands between two dense objects, like between the petrous bones in the head or across the pelvis.
And the big problem for us is?
The big problem is that these artifacts mean the Hounsfield units in those regions are wrong. They don't accurately reflect the true linear attenuation coefficient, and therefore, when the TPS uses the calibration curve,
it assigns the wrong electron density.
Exactly, leading to potential errors in the dose calculation in those areas. Modern scanners use heavy filtration and sophisticated reconstruction algorithms, like iterative reconstruction, partly to mitigate beam hardening effects, but it's still something you need to be aware of, especially when planning through areas with lots of bone or if contrast is present. Always look critically at your planning CT.
Okay, that's a fantastic overview of CT. Let's completely switch gears now to MRI physics. We said CT is the electron density expert. MRI is often called the soft tissue specialist. Big plus, no ionizing radiation.
That's a huge advantage, absolutely. MRI excels at providing really amazing contrast between different types of soft tissues, often way better than CT, and its physics is totally different. It relies on the magnetic properties of atomic nuclei.
Specifically hydrogen protons.
Primarily hydrogen protons, yes, because hydrogen is the most abundant element in the body, mostly in water, H2O, and fat molecules. These protons act like tiny spinning magnets. MRI is all about manipulating these tiny magnets using external magnetic fields and radio waves and then listening to the signals they give off as they return to normal.
Okay, so how does the MRI scanner actually do that? What's the setup?
The setup involves several key components working together. First, and most prominently, there's the B0 field, the main magnet. The patient lies inside the bore of a very powerful static magnet. Static meaning it's constant over time, always on.
And these are superconducting magnets.
Usually, yes, for the high field strengths we use clinically, like 1.5 Tesla or 3 Tesla, these are incredibly strong fields, tens of thousands of times stronger than Earth's magnetic field. They require superconducting wires cooled with liquid helium to near absolute zero.
Wow. What does this strong B0 field do to the protons in the body?
The hydrogen protons, with their little magnetic moments, align themselves with this powerful external B0 field. They don't all align perfectly, but slightly more align parallel to the field, the lower energy state, than anti-parallel, the higher energy state. This slight excess alignment creates a net magnetization vector for the whole tissue volume that points along the direction of B0.
Okay, so step 1, align the protons with the big magnet. What's next?
Step 2 is excitation. We need to knock that net magnetization away from the B0 direction. This is done using an RF coil and the B1 field. An RF coil, which is like an antenna, transmits radio frequency, RF, pulses into the patient. This RF pulse is actually a small oscillating magnetic field called B1, and it's applied perpendicular to the main B0 field.
And this RF pulse has to be at a specific frequency.
Critically important, yes. For the protons to absorb energy from this B1 pulse and get perturbed, the frequency of the RF pulse must exactly match something called the Larmor frequency of the protons in that B0 field.
Larmor frequency, what determines that?
The Larmor frequency is the natural frequency at which the protons precess, or wobble like a spinning top, when they're in the B0 magnetic field. It's specific to the type of nucleus, hydrogen protons here, and crucially, it's directly proportional to the strength of the magnetic field, B0.
Is there an equation?
Yep, the Larmor equation. Conceptually, Larmor frequency equals a constant, the gyromagnetic ratio for hydrogen, times the B0 field strength. So if you double the B0 field strength, for example, go from 1.5T to 3T, you double the Larmor frequency.
Okay, so you transmit an RF pulse at the Larmor frequency?
Yeah.
What happens then?
Resonance occurs. The protons efficiently absorb energy from the RF pulse. This absorbed energy does two main things. It tips the net magnetization vector away from the B0 direction, typically into the transverse plane, the XY plane perpendicular to B0, and it forces the individual precessing protons into phase coherence. They start wobbling together in sync.
So we excite them, tip them over, and get them spinning together, and we just listen.
Pretty much. That's relaxation and signal detection. As soon as the RF pulse, P1, is turned off, the excited protons immediately start to relax back towards their equilibrium state, which is having the net magnetization aligned back along B0.
They get back the energy they absorbed.
Exactly. As they relax, they release that absorbed RF energy. This released energy is emitted as a faint, oscillating RF signal. That's the actual MR signal we detect. Receiver coils, which are also antenna, sometimes the same coil that transmitted, sometimes separate surface coils placed closer to the patient, pick up this faint signal.
And here's the key part for contrast, right? It's the rate of this relaxation that's different in different tissues.
Exactly. That's the fundamental source of MRI contrast. Relaxation times. Different tissues relax back to equilibrium at different rates. Why? Because the local molecular environment surrounding the protons is different in fat versus muscle versus water versus tumor. These differences affect how quickly the protons can exchange energy or lose phase coherence.
And there are two main types of relaxation, T1 and T2.
Yes. Two main relaxation processes, each with its own characteristic time constant, T1 and T2. First, T1 relaxation, also called longitudinal relaxation or spin lattice relaxation. T1 is the time constant describing how quickly the net magnetization recovers back along the longitudinal direction, the direction of B0. Think of it as the protons giving their excess energy back to the surrounding molecular lattice.
And tissues have different T1 times.
Yes. Tissues where protons can efficiently transfer energy to the lattice have short T1 times. Fat is a classic example. It has a short T1. Water has a very long T1.
How does this affect the image?
On T1-weighted images, tissues with short T1 times, like fat, recover quickly between RF pulses and thus produce a strong signal, appearing bright. Tissues with long T1 times, like water or CSF, don't recover much between pulses if the pulse repetition time is short and appear dark.
Okay, so T1 is longitudinal recovery. What's T2?
T2 relaxation, also called transverse relaxation or spin-spin relaxation. Remember how the RF pulse forced the protons to precess and phase in the transverse plane?
Right, they're spinning together.
Well, T2 relaxation describes how quickly they lose that phase coherence. They start to fan out and get out of sync with each other in the transverse plane. This happens because each proton experiences slightly different local magnetic fields due to the magnetic fields of its neighboring protons. Spin-spin interaction.
So they dephase. And this happens at different rates too.
Yes. In tissues where protons are relatively free to move, like water or CSF, they maintain phase coherence for longer. They have long T2 times. In tissues where molecules are more restricted or contain paramagnetic substances like iron, the dephasing happens much faster. They have short T2 times.
And how does T2 affect the image?
On T2-weighted images, tissues with long T2 times, like water, CSF, edema, many tumors, maintain their transverse signal for longer and therefore appear bright. Tissues with short T2 times lose their signal quickly and appear dark. Oh, and a key physics point to always remember. For any given tissue, the T1 relaxation time is always longer than or equal to the T2 relaxation. T2 decay is always faster, or at best equal to T1 recovery.
T1 equals T2. Got it. So T1 is recovery along B0. T2 is decay in the transverse plane due to dephasing. And by cleverly timing the RF pulses, and when we listen for the signal, we can make images that emphasize one effect over the other. That's image weighting.
Exactly. That's the power of pulse sequences and image weighting. By choosing specific timings for the RF pulses and for when we acquire the MR signal, the echo, we can control whether the image contrast primarily reflects differences in T1, T2, or sometimes just the proton density itself.
And the key timing parameters are TR and TE.
Yes, the two most fundamental timing parameters you absolutely have to know are TR, the repetition time, and TE, the echo time. TR is the time between the start of successive RF excitation pulse cycles. It controls how much T1 relaxation occurs between excitation.
The short TR emphasizes T1 differences.
Right. If you use a short TR, tissues with long T1, like water, don't have time to fully recover their longitudinal magnetization before the next pulse hits them, so their signal is suppressed. Tissues with short T1, like fat, recover more, giving a stronger signal. A long TR allows most tissues to fully recover, so T1 differences become less apparent.
Okay. And TE, echo time.
TE is the time between the initial RF excitation pulse and when the peak of the MR signal, the echo, is actually measured or acquired. TE controls how much T2 decay occurs before we listen.
So long TE emphasizes T2 differences.
Exactly. If you use a short TE, you capture the signal very quickly before much T2 decay has happened, minimizing T2 influence. If you use a long TE, you wait longer. Tissues with short T2 times will have lost most of their transverse signal by then and appear dark. Tissues with long T2 times, like water, will still have significant signal left and appear bright.
Okay, so let's put TR and TE together. How do we get the main image weightings? T1 weighted.
T1 weighted images, T1W. You use a short TR and a short TE. The short TR maximizes T1 contrast, suppressing long T1 tissues, and the short TE minimizes T2 contrast. Remember the result. Fat is bright, water is dark. T1W images are generally great for visualizing anatomy, showing clear details between different structures. They're also the standard sequence used after giving gadolinium contrast.
Why gadolinium?
Gadolinium is a paramagnetic contrast agent that dramatically shortens the T1 relaxation time of tissues where it accumulates. So things like enhancing tumors or areas of inflammation become very bright on post-contrast T1W images.
Okay. What about T2 weighted?
T2 weighted images, T2W, use a long TR and a long TE. The long TR allows most tissues to recover their longitudinal magnetization, minimizing T1 effects. The long TE allows significant T2 decay to occur, maximizing T2 contrast. Remember the result. Water, CSF, fluid, edema, most pathologies appear bright. T2W images are often called pathology sequences because many disease processes involve increased water content, which shows up bright.
So T1 for anatomy, T2 for pathology, generally speaking.
That's a good general rule of thumb. T1 anatomy, fat bright. T2 pathology, water bright.
Is there another common weighting? Proton density?
Yes, proton density weighted, PDW. Use a long TR and a short TE. The long TR minimizes T1 weighting, the short TE minimizes T2 weighting. So the contrast primarily reflects the actual concentration or density of hydrogen protons in the tissue. These are maybe less commonly used for tumor delineation in RT compared to T1W and T2W, but they can be useful, for instance, in musculoskeletal imaging to see cartilage or ligaments well.
Okay, so understanding TR and TE lets you predict the image contrast. Now, how is MRI actually used in radiation therapy planning, given that it doesn't give us the electron density we need for dose calcs?
Right, that's the key limitation, but MRI is still incredibly valuable for planning for several reasons. Its main strength, as we said, is superior soft tissue delineation.
Seeing the tumor or normal tissues better.
Much better in many cases, compared to CT. Think about brain tumors, distinguishing the tumor from surrounding edema or normal brain structures. Or prostate cancer, seeing the gland, the capsule, the seminal vesicles. Head and neck cancers, pelvic cancers. MRI often lets you define the gross tumor volume, GTV, and critical organs at risk, with much greater confidence and precision than CT alone.
So you contour on the MRI?
Often, yes. The standard workflow in many sites is to acquire both a planning CT and a diagnostic quality MRI, often done in the treatment position if possible. Then you fuse the MRI dataset to the CT dataset in the treatment planning system.
Image fusion or registration.
Exactly. You spatially align the MRI volume with the CT volume.
Yeah.
Then you can leverage the strengths of both. You use the excellent soft tissue contrast on the MRI, maybe the T2W for tumor, T1W for anatomy, to draw your contours accurately.
And you use the CT.
You use the CT for its geometric accuracy. MRIs can sometimes have subtle geometric distortions. And, most importantly, for its Hounsfield unit map, which the TPS converts into the electron density map needed for the dose calculation. So you contour on the fused MRI CT, but the dose is calculated on the CT density.
Combining the best of both worlds.
Precisely. Now, it's crucial to hammer this point home again. MRI signal intensity does not directly provide electron density information for dose calculation. The signal depends on T1, T2, proton density, flow, diffusion, a whole bunch of things, but not electron density in a way we can easily calibrate like CTHU.
So if you only had an MRI for planning, which is sometimes discussed.
MRI-only planning workflows exist, but they require special techniques. You either have to generate a synthetic CT image from the MRI data using complex algorithms, or you have to manually assign bulk density values, like assigning water density to muscle, air density to cavities, maybe a standard bone density, to different contoured structures. You cannot just use the raw MRI signal intensities for dose calculation. That would lead to massive errors.
Got it. MRI for drawing soft tissues, CT for geometry and density calculation, fusion brings them together. And know your T1 versus T2 for interpreting what you're seeing.
Absolutely. T1W, anatomy, fat bright. T2W, pathology, water fluid bright. Burn that into your brain. Okay, now, MRI safety. This is huge GE. Hugely important for boards, absolutely critical for day-to-day practice, and the risks are completely different from the ionizing radiation risks we manage with CT or LINACs.
What are the absolute must-know safety concerns with MRI? The big dangers.
You absolutely have to be vigilant about these. First, and probably the most dramatic, the projectile effect.
Things flying into the magnet.
Exactly. That main B0 field, the big static magnet, is incredibly strong, and it's always on, even when the scanner isn't actively scanning. Any ferromagnetic object, things containing iron, some types of steel brought near the magnet can be violently pulled towards it.
What kind of objects?
Anything. Pens, scissors, paper clips, keys, stethoscopes, but also bigger things like oxygen tanks, IV poles, wheelchairs, floor buffers, toolboxes. If these get too close, they become extremely dangerous projectiles. They can fly into the magnet bore at high speed, injuring or even killing anyone in the way and causing catastrophic damage to the multi-million-dollar scanner.
So screening is critical.
Absolutely paramount.
Oh.
Strict screening of everyone, patient, staff, visitors, maintenance crew, and everything entering the MRI scan room, Zone Phi, is non-negotiable. Patients need to be screened for implants, pacemakers, aneurysm clips, metal fragments. Personnel need to remove watches, keys, check tools. Equipment must be certified as MR safe or MR conditional. Titanium implants are generally okay, but many other metals are definite no-goes. Never assume something is safe.
Okay, projectile effect is number one. What else?
Second, RF heating. Related to SAR, remember those radio frequency pulses, B1, we used to excite the protons? Those RF pulses deposit energy into the patient's tissues, and this energy deposition causes tissue heating. The amount of energy absorbed per unit mass per unit time is quantified by the specific absorption rate, or SAR, measured in watts per kilogram, WK.
Is this heating dangerous?
It can be if it gets too high. There are regulatory limits on SAR levels to prevent excessive tissue heating, which could potentially cause burns or be harmful, especially for patients with compromised thermoregulation or in sensitive areas like the eyes or testes. The MRI scanner monitors and controls the RF power deposition to stay within safe SAR limits based on the patient's weight and the specific pulse sequence being used.
Okay, projectile effect, RF heating. What's third?
Third, gradient field-induced currents. We mentioned briefly that rapidly switching magnetic fields, called gradient fields, are used for spatial localization, figuring out where the signal is coming from. These gradient fields are turned on and off very quickly during the scan. According to Faraday's law of induction, this rapid switching of magnetic fields can induce small electrical currents in conductive tissues within the patient's body.
Does the patient feel that?
Sometimes, yes. It can cause peripheral nerve stimulation, which might feel like tingling, twitching, tapping, or even muscle contractions, usually in the extremities or trunk. Scanner manufacturers design the gradients and limit the rate of switching the DBDT to keep these effects below levels that cause significant discomfort or risk. But it's something patients might experience, especially with faster, more powerful sequences.
Okay. Fourth safety concern.
Fourth, acoustic noise. This is something anyone who's had an MRI knows well, that loud, banging, knocking, buzzing sound.
What causes that?
It's those same rapidly switching gradient coils. When the electrical current pulses through the gradient coils, which are sitting inside the very strong main B0 magnetic field, they experience a physical force, the Lorentz force. This force causes the coils to physically vibrate very rapidly against their mountings, and that vibration creates the loud acoustic noise.
And it is loud.
Extremely loud. Noise levels can easily exceed 100 decibels, like a jackhammer or a rock concert. This can cause patient anxiety, and more importantly, temporary or even permanent hearing damage if proper protection isn't. So hearing protection earplugs or noise-canceling headphones is mandatory for the patient and anyone else who has to be in the scan room during active scanning.
Makes sense. Projectile, RF heating, induced currents, noise. Is there one more major one?
Yes, the fifth one, which is rare but potentially very serious, quench.
Which? What's that?
This applies to superconducting magnets. A quench is when the superconducting magnet suddenly loses its superconductivity. The magnetic field collapses rapidly.
Why would that happen?
It could be triggered by a failure in the cryogenic cooling system, allowing the superconducting wires to warm up. Or sometimes it's initiated intentionally in an extreme emergency using an emergency quench button. When superconductivity is lost, the enormous amount of stored magnetic energy is dissipated very quickly as heat in the magnet coils.
And that heat does what?
It causes the liquid helium coolant surrounding the coils to boil off explosively, turning into a huge volume of extremely cold helium gas. This gas must be safely vented out of the building through a dedicated, large-diameter quench pipe.
What are the risks if a quench happens?
Several major risks. First, asphyxiation. The rapidly expanding helium gas can displace all the oxygen in the scan room very quickly. Second, frostbite. The escaping helium gas is incredibly cold, -269 degrees Celsius. Third, potential pressure buildup and damage if the vent pipe is blocked or fails. Emergency procedures for safely evacuating the patient and staff from the room during a quench are absolutely critical, and the integrity of that quench pipe is vital.
Wow. Okay, 5 big safety issues. Projectile, RF heating, ALSAR, gradient currents, nerve stimulation, acoustic noise, and quench. Let's do a quick clinical scenario on safety. Patient comes for MRI sim. Screening form mentions they might have had a tiny metal fragment in their eye years ago from grinding metal, never caused problems. What's the absolute next step?
That's a classic and critical scenario.
Yeah.
Any history, even vague or uncertain, of a potential intraocular metallic foreign body is a huge red flag for MRI.
Because the magnet could move it.
Exactly. The strong magnetic field could potentially pull on that fragment, causing it to move or rotate within the eye, leading to severe injury, hemorrhage, retinal detachment, even blindness. You absolutely cannot proceed with the MRI based just on the patient saying, "It never bothered me."
So what do you do?
Standard protocol, absolutely required, is to obtain imaging to definitively rule out or retain ferromagnetic foreign body before the patient goes anywhere near the MRI scanner. Usually this means getting plain orbital X-rays or, even better, a dedicated thin-slice orbital CT scan. Only if those images clearly show no metallic foreign body can the MRI proceed safely. Patient safety trumps everything else here. Clear the eye first.
Great example. So integrating CT and MRI is really key for optimal planning. using the strengths of each.
Absolutely critical. They complement each other beautifully when used together correctly.
So let's summarize their roles for planning one last time. CT.
Computed tomography, CT, it's the backbone, provides the essential electron density map via Hounsfield units derived from X-ray attenuation, which is indispensable for accurate dose calculation using that scanner-specific HU to electron density calibration curve. Consistency in that calibration is vital. CT is also great for defining bony anatomy clearly and is generally less prone to geometric distortions than MRI.
And MRI.
Magnetic resonance imaging, MRI. No ionizing radiation. Its superpower is unparalleled soft tissue visualization. It uses magnetic fields and RF pulses to map proton relaxation, T1 and T2 times. This gives amazing contrast for delineating tumors and OARs in many sites: brain, prostate, pelvis, head, neck. Image fusion with CT is standard practice, combining MRI's contouring accuracy with CT's density info. Crucially, MRI does not give direct electron density for dose calc. Remember T1W, fat bright anatomy, versus T2W, water bright pathology.
And DICOM is the silent hero tying it all together.
Correct. DICOM is the indispensable standard ensuring all this complex data, CTs, MRIs, contours, RT structure sets, plans, RT plans, doses, RT doses, can be transferred, archived, and used reliably and safely across all our different systems. Without it, modern multimodality RT wouldn't work.
Okay, fantastic summary. Let's shift now to some final clinical pearls and prep for a board blitz. What are the absolute high-yield must-remember points for boards covering CT and MRI physics and safety? If you have 5 minutes before the exam, what do you review?
All right, the rapid-fire high-yield list. DICOM, universal standard, no header, patient text, spatial info, plus image data. Know the RT objects, RT structure set contours data, RT plan beam params, RT dose map dash image. DRRs, ports, each should have ports, each interoperability for safety, used in the mnemonic, plan structurally, dose images.
Got it. C2.
CT measures X-ray linear attenuation, mu scale to Hounsfield units, HOU, key values, water 0, air measure 1000, bone plus 1000 approx. Primary RT role. Provides electron density for dose calc via CT to ED calibration curve. Scanner KVP specific. Understand helical scanning and pitch, speedos res trade-off. Beware artifacts like beam hardening messing up HU values.
MRI.
MRI, and no ionizing radiation. Uses strong static B0 field, RF pulses B1 at Larmor frequency. Detects signal during proton relaxation T1 and T2. Contrast from relaxation times. Differentiate T1W, short TRTE, fat bright, water dark, anatomy postgad from T2W. Long TRTE, water fluid bright, pathology edema. Provides great soft tissue contrast, but no direct electron density for dose calc. Fusion needed.
And MRI safety.
Yeah.
Super important.
Paramount. MRI safety, projectile effect, for magnetic objects, dangerous. RF heating, SAR limits, gradient-induced currents, nerve stim. Acoustic noise, hearing protection mandatory. Quench, rare but serious, asphyxia, frostbite risk. Know these 5 core.
Excellent. Ready for a quick board blitz? 4 questions to lock this in.
Let's do it. Fire away.
Question 1. Which statement regarding Hounsfield units in CT is most accurate? A, HU are directly proportional to T2 relaxation time.
B.
An HU of 0 typically represents air attenuation. C, HU provide direct measure of proton density. D, HU are derived from X-ray linear attenuation coefficients scaled relative to water.
Okay, think it through. A is wrong, HU is CT, T2 is MRI. B is wrong, HU0 is water, air is negative 1000. C is wrong, proton density is MRI. HU relates to electron density in RT. D sounds right. HU are scaled linear attenuation coefficients relative to water. So the answer is D.
Correct. D is the answer. HU are calculated by scaling measured mu relative to water's mu. Question 2. A patient with a non-MR conditional cardiac pacemaker is scheduled for a radiation therapy planning scan. Which imaging modality would generally be contraindicated or require extreme caution in specialized protocols? A, computed tomography, CT. B, magnetic resonance imaging, MRI. C, ultrasound. D, planar X-ray.
Okay, pacemaker, strong magnetic fields are the big worry. CT uses X-rays, ultrasound uses sound waves, planar X-ray uses X-rays. MRI uses strong static and changing magnetic fields and RF pulses. That's the danger zone for a pacemaker. So the answer must be B, MRI.
Correct again. B. The strong magnetic fields and RF pulses in MRI can cause serious issues with non-conditional pacemakers, malfunction, heating, movement. Extreme caution or contraindication is necessary. Question 3. In magnetic resonance imaging, MRI, T1 relaxation refers to A, decay of transverse magnetization due to spin-spin interactions. B, Recovery of longitudinal magnetization along the main magnetic field, B, 0. C, signal strength based on the concentration of hydrogen nuclei. D, feasting of spins due to the local magnetic field and homogeneities.
All right, T1, relaxation. Let's see. A sounds like T2, spin, transverse decay. B is recovery of longitudinal magnetization along B0, spin lattice. C is proton density. D sounds like T2, star decay and homogeneities. So T1 is B.
Exactly right. The answer is B. T1 is the recovery of longitudinal magnetization along B0. A describes T2. Last question, question 4. The DICOM RT object responsible for storing the contoured outlines of tumors and organs at risk is the A, RT plan, B, RT dose, C, RT structure set, D, RT image.
Okay, contours. Drawings of tumors and OARs. Remember the mnemonic. Plans structurally, dose images. Contours are the structure, so it must be RT structure set. Answer C.
Perfect. C is correct. RT structure set contains the geometric definitions, contours of structures like GTV, CTV, PTV, and OARs used for planning. RT plan has beam parameters. RT dose has the dose map. RT image has associated images like DRRs.
So wrapping it all up, DICOM is that essential universal language for interoperability. CT gives us our crucial electron density map via Hounsfield units from X-ray attenuation, vital for dose calculation. MRI uses magnetic fields and RF pulses for amazing soft tissue contrast via T1 and T2 relaxation times, perfect for contouring but no direct density info. And never forget MRI safety, especially screening for projectiles.
Knowing the distinct physics, the capabilities, the limitations, and the safety concerns of CT and MRI is just absolutely fundamental to your practice as a radiation oncologist. It underlies so much of what you do, from contouring to plan evaluation to just keeping patients safe. Now, remembering all these intricate physics details after you finally pass your physics boards, that's the real challenge. Good luck with that. For more help with board preparation, practice oral boards, and more physics reviews tailored for residents, definitely check out RadOncSmartLearn.com. Thanks everyone for tuning in. We hope this deep dive into CT and MRI physics was useful for your learning and review.